Let's look at the keywords first before understanding the research paper. Breast conserving therapy or BCT is a treatment for early stage breast cancer that involves removing only the tumor and not the whole breast, followed by radiation therapy. It's an alternative to mastectomy. Radiation therapy is a cancer treatment that use high dose of radiation like X-ray mainly to kill cancer cell and shrink tumor. Brachytherapy is a type of radiation therapy where a source of radiation is placed inside your body near the tumor, and it's often used to treat cancer of the head, neck, breast, cervix, prostate and eyes. PBI is a treatment that focuses on the area where the cancer is most likely to return and using precise radiation beam to kill the cancer cell in a smaller area of the breast. It also known as accelerated partial breast radiation. BRCA1 or BRCA2 are DNA repair genes that hold the code for BRCA1 and BRCA2 proteins, which repair DNA damages in cells. Inherited mutation in BRCA1 and BRCA2 genes increase the risk of breast cancer and ovarian cancer. Multicentricity is the presence of more than one center in tumors. Multifocality is the presence of several focuses or several parts that correct vision at different focal distances. LVSI is lymphovascular space involvement. It is mainly the presence of cancer in lymphatic or vascular spaces within the uterine myometrium. ER status is if the breast cancer cells have receptors that can bind to the hormone estrogen. Lymph node status describes whether or not the lymph nodes in the underarm area contain cancer. And lymph node surgery is a surgical procedure to remove the lymph nodes. Extensive intracapsular component or EIC is used to describe the presence of cancer cells within the capsule of a lymph node. Neoadjuvant therapy is a treatment such as chemotherapy, hormone therapy or radiation therapy, and it is mainly given before the main treatment to decrease the size of a tumor. This table is a guideline from the American Society for Radiation Oncology for determining the suitability of patients for a specific type of breast cancer treatment called APBI. Suitable patients meet all the listed criteria such as being 60 years or older, having a tumor size less than 2 cm and not having certain genetic mutation. Cautionary patients meet any of the listed criteria such as being aged between 50 and 59 or having a tumor size between 2.1 and 3 cm. Unsuitable patients meet any of the listed criteria such as being younger than 50 or having a tumor size larger than 3 cm. APBI has several advantages over WBI such as shorter treatment times and less radiation exposure to healthy tissues. But there's a concern that APBI might leave untreated cancer cells elsewhere in the breast. Despite this, APBI use has increased even after evidence shows that WBI can improve long-term survival after surgery. Given these conflicting findings, experts agree that careful patient selection for APBI is needed until more data from large trials are available. To help doctors decide who might be a good candidate for APBI, the American Society for Radiation Oncology created a task force. They published a consensus statement with guidelines on patient selection and best practices for APBI use outside of clinical trials. The next topic is materials and methods. Participants. The study was done on a device called Mammocyte. It is used for a type of breast cancer treatment, and the study was done from 2002 to 2004. It involved 97 places and they collected data on how the device was used. ASTRO CS groups. Patients are categorized into 3 groups: suitable, cautionary and unsuitable, based on different factors such as age, gene mutation, tumor size and type, grade of the tumor, lymph node status, margin status, type of cancer cell and use of pre-surgery treatments. Outcome measures. The study looked at different outcomes. One was if the cancer came back in the treated breast. This is called IBTR. It also looked at if the cancer spread to the lymph nodes, and this is called an RNF. It also checked if the cancer spread to the other parts of the body. This is called a DM. These outcomes were looked at for two types of breast cancer. One is invasive breast cancer and the other one is DCIS. The study also looked at survival rates. DFS is if a person did not have any more cancer. CSS is if a person did not die from breast cancer. OS is if a person did not die from any cause. All these times were counted from when the radiation treatment ended. Statistical analysis. The study used the Kaplan-Meier method to estimate the likelihood of IBTR, RNF, DM, DFS, CSS and OS. The study used a tool called SAS version 8.0 for analysis. The results were considered significant if the p-value was less than 0.05. The study also looked at different characteristics of patients. This include the size and type of the tumor, and if the tumor was sensitive to estrogen, and if the cancer had spread to the lymph nodes. The table shows the number and percentage of patients with these characteristics. For example, 93.7% of patients with invasive breast cancer had a tumor size of 2 cm or less. 83.8% of these patients had tumors that were sensitive to estrogen. 91.3% of these patients had cancer that had not spread to the lymph nodes. Discussion. The study looked at ASTRO-CS group using APBI of protocol. No big differences were found in 5-year IBTR rate among suitable, cautionary or unsuitable groups. The rates were 2.59%, 5.43% and 5.28%. The difference was not big enough to be important. For patients with invasive breast cancer, only negative ER status was linked to IBTR. The odds ratio was 4.01. For patients with DCIS, only age under 50 and close positive margin were linked to IBTR. The odds ratio were 1.115 and 7.813. Development of ASTRO-CS on APBI. ASTRO-CS was made for APBI. Over 50k US women have been treated with mammocide. APBI use has grown despite limited long-term data. Other APBI methods have also been used. Experts suggest careful patient selection for APBI until phase 3 trial results are available. The task force acknowledged the lack of clinical data, so they relied on their knowledge of risk factors for IBTR after WPI. The ASTRO task force created their grouping without much long-term data on APBI efficiency. Patients in the cautionary and unsuitable groups may still be suitable for APBI. The task force included patients in the suitable category only if there was enough data. The ASTRO task force identified suitable patients for APBI using limited data from APBI studies. They acknowledged more patients might be suitable for APBI but lacked evidence. No data shows cautionary or unsuitable patients have worse IBR rate than suitable ones. Some studies showed acceptable IBTR rate in higher risk patients. The task force recognized the need for ongoing data collection and potential guide updates. Current analysis or study limitations. This study applied ASTRO-CS guidelines for APBI to the largest patient group treated with APBI. The guideline didn't differentiate who should get APBI. The study included 71% of the group due to insufficient data. The suitable, cautionary and unsuitable group didn't include all ASTRO-CS characteristics. To control possible mistakes in classifying patients, univariate analysis was done. This was done on the predictive ability of the CS group. It compared different groups, but none were linked to IBTR. Despite limitations, the result could help refine the CS group with more APBI data. Risk factors of cancer recurrence after APBI. ER status and tumor size were linked to outcome in invasive breast cancer. Other risk factors for IBTR in APBI need study. Similar IBTR rates were found in APBI and WBI patients. CS groups were linked to ORS, RNF and DM rates but not IBTR. More data could guide changes to ASTRO-CS on APBI, and the ASTRO-CS groups identified a low IBTR group for APBI but didn't differentiate who should get WBI. These findings support including high-risk patients in phase 3 trials.